Hello everyone and welcome back to my playlist of 10 Teachers Gynaecology. My name is Professor Asif Lectures and you are watching Dr Asif Lectures. And today we are going to cover chapter number 7 from 10 Teachers Gynaecology. And the topic of this chapter is subfertility, single point agenda, where all the listeners will at the end of the lecture will understand the definition and causes of subfertility and describe the main concept of ovarian reserve. That's a very important topic these days. Understand the history, examination, investigation relevant to subfertility. Although ये हमने ऑलरेडी चैप्टर 2 में डिटेल में इसके बेसिक प्रिंसिपल्स तो कर रखे हैं कि हिस्ट्री एग्जामिनेशन में व्हाट आर द इम्पोर्टेंट पॉइंट्स, बट वी विल वन मोर टाइम recapitulate all those concepts, particularly pertaining to subfertility. We shall be understanding the provision and regulation of fertility treatment, explain the process and procedures involved in assisted reproductive, जिसको ART भी कहते हैं, assisted reproductive treatment, and understand the outcomes and success of ART. So let us begin. A delay in conception is one of the commonest reasons that a woman will consult the doctor. So this is what subfertility is, that they're trying for having a baby, but the baby is just not happening. Fertilization is not happening. But there has to be a definition कि बच्चा नहीं हो रहा, कि what is the exact definition. So there is no one universal definition of subfertility, but the commonest one, which is accepted across the discipline of gynae, is the failure to conceive after 12 months of regular unprotected intercourse. The couple should have been trying for at least 12 months, which is 1 year, unprotected intercourse, no contraceptives, no condoms, nothing. And intentionally they are intending to have the baby. Or 1 साल के attempts के बाद भी, if nothing is happening, then you would define this. Then you will label it as subfertility. The incidence of subfertility is thought to affect about 1 in 7 heterosexual couples. So 1 in 7 heterosexuals. So very, very common. There has been a small increase in the prevalence of reported infertility. Infertility is then the absolute absence of having baby, fertilization. And a large number of couples accessing treatment services over the last 10 years in the UK. The number has been increasing. This may be related to increase in the acceptance of fertility treatment and reduction in couples who reassigning themselves to childlessness. So previous times में होता था कि if there is subfertility or infertility, they kind of accepted it. But now we have a lot of techniques available. For example, अभी हम पढ़ेंगे भी इसमें ना, ART, assisted reproductive treatments. So many people go for that and they try and have the baby by medical intervention. The diagnosis of subfertility in a couple may be primary in couples that have never conceived together, or secondary in couples that have previously conceived together, although either partner may have conceived in a different relationship. So पहले अगर बेबी हुआ है, पहले कंसीव किया है और अब कंसीव नहीं हो रहा, that is secondary. हर चीज में ऐसे ही होता है ना. फर्स्ट टाइम अगर बिल्कुल जैसे amenorrhea में था कि if from the very beginning menses never happened, this is primary amenorrhea. If they happened but then they stopped, secondary amenorrhea. बिल्कुल यहाँ भी ऐसे ही, अगर पहले कंसीव हुआ है बेबी तो प्राइमरी नहीं है, now this is secondary subfertility. But if never conceived, this is primary. Specialist terms should be available to offer, right? Natural conception, आपको पता है कि healthy couple having frequent intercourse have about 18 to 20% chance of conceiving in a single menstrual cycle. So every single menstrual cycle has a chance of around 18 to 20% if they are trying to conceive after the intercourse. As a species, this makes us relatively infertile, because even with all the favorable condition, without unprotected intercourse, with ovulation, the chances are only 18 to 20%. So human beings are relatively infertile. What a nice word it is. With this capacity, look at the world population. सोचें जरा ये परसेंटेज अगर ज्यादा होती तो कहाँ पहुंचता. This is, of course, a cumulative increase in pregnancy rates over time as couples try to conception. Within 6 months, 70% of the couples will have conceived. After 12 months, 80%, and after 24 months, about 90% will achieve a pregnancy if there is nothing wrong, right? The most important factor affecting fertility is the female age, which is related to decline in the quality and quantity of eggs. Obviously, the more the female age is, the quality and the quantity of egg is disturbed, and then the chances of having appropriate conception decline. Female fertility tends to fall sharply over the age of 36. So anyone getting over the age of 36, they say the fertility these are the data suggestive of this statement, with a further dip after the age of 40. However, there is considerable variation in biological age, और ये ऐसा नहीं है कि ये कोई rule of thumb है. Many people I know conceive after the age of 40, absolutely fine, right? However, you should remember that the quality and the quantity of egg, they decline, and also when we say the quality of egg decline, it also means that there are some genetic and chromosomal aberrations which start erupting, and that is the very reason that some of the syndromes such as Down syndrome is common in females being pregnant after the age of 40. उनके बेबीज को ज़्यादा चांसेस होते हैं. Male age is also an important factor. Semen quality tend to fall in the man over the age of 50, while frequency of intercourse tends to fall in men over. So libido भी कम होना शुरू होता है, and the quality of sexual intercourse decline as well after 50, and overall quality of semen as well. Sperm count, sperm motility, all these things are affected. Now, both frequency and timing of sexual intercourse impact strongly on the chance of conceiving naturally. Timing is very important. ये जो timing वाली बात है, you should understand that basically means if you are having sexual intercourse at the time of ovulation, which is around day 14. So if you are trying in day 1 to day 7, for example, well, day 1 to day 4 and 5 will be bleeding anyways, but that is an anovulatory period. इसी तरह if you are trying after 20 days and 28 days के बीच में during the menstrual cycle, if somebody is trying, that is also an anovulatory period. So the ovulation happens at day 14 of the menstrual cycle, and this is where you should be focusing on. Couples having intercourse 3 times a week are 3 times more likely to conceive. So the more you attempt, the more are the chances. Maximum efficiency is probably intercourse at every alternate day. Every alternate day, not daily, okay? Because then you have time to rebuild the semen resources as well. There should, however, be awareness among physicians and patients of the added stress and anxiety over medicalizing this advice can bring into couples. So many people get stressed, when pregnancy is not happening. So that should be avoided. उसके लिए counseling ज़रूरी है. उनको बताना पड़ेगा कि देखें success rate सिर्फ 18 to 20% है with every menstrual cycle. Just keep on trying alternate days, maybe a few times in one cycle. Increased frequency of the intercourse should be encouraged in the peri-ovulatory period. When we say peri-ovulatory period, that means day 14 पे ovulation है. So 2 to 3 days here and 2 to 3 days there, right? Between like 13 to, I would say, 17 days. Increase the frequency. This is your time period to attempt and target if you are planning for fertilization. Eggs are thought to be fertilized for about 12 to 24 hours post-ovulation. That's the most productive period. And if sperm reaches the vagina, which means intercourse happens during these days, this time of day 14, matlab within 24 hours ho to it's ideal, right? The fertile window for women will therefore be different depending on average length. Obviously, मैं ये जो कह रहा हूँ ना 14 days पे 2-3 दिन इधर 2-3 दिन उधर, the best is get sperm in on day 14. I mean, this is why also it is becoming very important to know when exactly is the female ovulating. Now, say for example, if female is counting from day 1 and she says today is day 14, should be my ovulation day, but ovulation can be somehow plus minus 1 day here or plus minus 1 day there. So this is why the devices which actually check using urine depistic devices, and basically they tell you this today is probably she is ovulating, because they then detect some metabolites, right? So starting from day 11, she should be checking, and if it is positive, that is your day to attempt. And this practice is now becoming very common. Couples are now very well aware of this, and they are using these devices, right? They exactly know when is the ovulation happening. Exactly se matlab ye hai ki they more or less know with pretty much confidence that this is the day when ovum is available, right? So external factors may influence the chance of conception. There is now strong evidence that smoking can decrease the quality of egg as well as sperm. So those who are smokers, उनकी motility disturb होगी, दोनों ही की. The role of alcohol and caffeine remains controversial. There is no compelling evidence to totally abstain from these while trying to conceive, but smoking is definitely a killer. Body mass index exerts a strong influence on fertility. Obviously, the more the body mass index, such as the patients with PCOS, they have obesity, so they have difficulty in conceiving. Now there are so many different causes of subfertility. पहले तो ये है कि subfertility में ना ये time आपको पता होना चाहिए कि 1 year तो definitely try किया हो unprotected. यानी अगर आपके पास कोई couple आ जाता है, say for example they got married and they come to you at second month of their marriage life, and this is they are complaining that there is no baby, pregnancy nahi ho rahi. So that's actually something where you have to counsel them. No intervention needed, no test needed. Just ask them, keep trying. 1 year is the normal window, and increase the frequency, improve the timing. I've seen in my clinical practice many females, they are calculating their menstrual period days wrong. So I always tell them day 1 of the bleed is actually day 1 of the new cycle. This is how they have to count. So when the bleeding starts, that's day 1, right? Many female have the tendency of counting it in the wrong way. So they count it like this: day 1 of the bleed, day 5 the bleeding stop, and this is what they say is actually day 1 of the new menstrual cycle. It's actually not, right? And that then forwards the calculation 5 days from the actual time period. So imagine जो correct day था new menstrual cycle ka, that is the first day of the bleed, and starting from here, day 14 will come somewhere here. But if they are starting from the last day of the bleed, then day 14 will come somewhere here, and if they are trying getting pregnant on this particular time, they are missing this 5. So ovum release pehle ho gaya tha, wo dead bhi ho jayega, and they think this is the ovulation time. So the basic things, you have to calculate the days correctly. You have to be very careful that you have to attempt during the ovulation time period, and these devices can help. So all this happens with the appropriate medical discussion. Counseling zaruri hai, right? Now, the main causes of subfertility will vary in different countries. In the UK, for example, 30% of the subfertility is caused by male factor, 30% by female factors. So they are equally contributory, and 25% are unexplained, and 15% both male and female, or other causes, right? Female subfertility, for example, ovulatory disorders, tubal damage, uterine disorders such as fibroids. They are very common causes of subfertility, and endometriosis, any pathology in the uterus basically. Cigarette smoking reduces the fertility. Cigarette smoke is a killer, not only in females but also in males. General medical conditions such as diabetes, epilepsy, increased body weight, PCOS, these are all damaging, and reserves of the ovary in terms of ovum, they reduce with the passage of age as well, right? The common causes pertaining to the ovulatory issues are PCOS, number 1 killer, because this is directly associated with hormonal disturbances and problems with conceiving. Women with PCOS who suffer from oligomenorrhea due to anovulation may require some treatment, such as combined oral contraceptives. However, the hormonal treatment taken by women to regulate their period or help their hirsutism may be incompatible with getting pregnant. So, on one side, they need a treatment for PCOS. On the other side, this will be intervening with pregnancy. So, expert consultation must be conducted. Hypothalamic disorders are there. हमने पहले भी ये बात की थी, such as hyperprolactinoma. This will inhibit ovulation, thyroid problem. So, you need to get to the bottom. So, point ये है कि अगर if a couple is approaching you कि we are not able to conceive, first you need to see कि 1 साल हो गया है. You need to identify कि they are practicing and trying intercourse in the very correct manner in order to get pregnant. If all those things are fine and you label the female or the couple as being subfertile, this is where you start actually investigating what is wrong. कोई hormonal issue तो नहीं है, कोई blood test करवा लें, कोई ultrasound करवा लें. If you identify a disorder, fix that. If you don't, then attempt get help from ART or something like that. Okay. There can be tubal problems. अगर pelvic inflammatory disease for example हुई है, उससे tube fibrose हो सकता है, a blocked fallopian tube, adhesions, previous surgery, all these are important factors. Then there can be uterine problems such as fibroids, such as endometriosis or polyps, or sometimes during previous pregnancy there is an Asherman syndrome. So things depend upon what you are looking at. But once you define subfertility, then you will investigate what is the actual cause of this subfertility. Okay, there can be male factors, which is compromised sperm count or the quality, also directly associated with age. There is some evidence that sperm counts are falling, and there are various theories to explain this, including environmental and dietary issues. Spermatogonial cells, that produce sperm can be damaged by inflammation, which is orchitis, any previous radiotherapy, perhaps any surgery, diabetes, other hormonal problems, and some genetic causes. If somebody is suffering from a chromosomal disorder such as Klinefelter, or are there any microdeletions, and that is leading to azoospermia or oligozoospermia, so sperm count is reduced, all these factors. So obviously when you are investigating a couple with subfertility, you will be then investigating them both male and female, right? And you have to in history take care of these things which we discussed already. Male mein what is the age, length of time spent trying for pregnancy, 1 साल से कर रहे हैं ट्राई या नहीं कर रहे हैं, क्या फादर कोई पहले कोई प्रेगनेंसीज हुई हैं सेम वाइफ से या किसी और पार्टनर से, मम्स वगैरह तो नहीं रहा पास्ट में, बिकॉज दिस देन लीड टू ऑर्काइटिस एंड रिड्यूस स्पर्म काउंट, काम क्या करते हैं, कोई ट्रॉमा तो नहीं हुआ टेस्टिकुलर एरिया में, मेडिकल हिस्ट्री, दीज आर ऑल द क्वेश्चंस दैट यू टेक इन हिस्ट्री फ्रॉम मेल। और फीमेल्स में ये सारे क्वेश्चंस, कोई मेडिकल कंडीशन, कोई प्रीवियस आउटकम, कोई गायनी ऑप्स हिस्ट्री, एग्जामिनेशन आपने करनी है, टेस्टिकुलर एग्जामिनेशन यहाँ, एंड पेल्विक एंड एब्डोमिनल एग्जामिनेशन इन फीमेल्स, राइट? सो these are all the important points for history taking an examination. What investigations will you do? This depends upon what you are suspecting. So for example, if you are suspecting in female some hormonal issues, you will be going for FSH levels, LH levels. So let's go through investigations. It is usually preferable to diagnose a cause of subfertility so that an appropriate treatment can be given. Very important. You need to get down to the bottom. So if you don't identify what is wrong, you will not be able to treat it. However, when a detailed series of investigations, a significant delay can happen, but this is worth doing because you will then identify the cause. There is some debate as to when investigation should be started, considering such as age, level of anxiety. So I think give them the time which is defined by the definition, 1 year, and then you start investigating what is wrong. Okay, females may you do the hormone profile in the blood. Obviously you need to check FSH and LH level, AMH levels, and you would also do some hormonal studies such as thyroid function test, prolactin levels and testosterone levels. They will all give you a clue if the metabolic milieu of the body is fine or not. You also check for infections such as chlamydia, perhaps HIV also. Sometimes you need to do transvaginal ultrasound if, for example, you are suspecting fibroids or any organic problem within the uterus. So it depends upon what you are suspecting. You order your prescriptions in that direction. Measurement of ovarian reserves. Female reproductive potential is directly proportionate to the number of oocytes, right? Ovarian reserve decline after the age of 35, and even before 35 if they are exposed to some serious drugs such as chemotherapy, God forbid. The ovarian reserves can help to predict the response of ART. You need to see कि ovary के अंदर कितना माल मवाद मौजूद है, how much ova are there, and you check that, right? This is calculated by various techniques. You can you can have a transvaginal ultrasound, see what is the response, what is the ovarian reserve. AMH is produced by the granulosa cell of the ovarian follicle and does not change in response to gonadotrophin during the menstrual cycle. As a result, it can be measured and compared from any point in the cycle. At present is the most successful biomarker. This is something which many students don't know, right? However, you should be very careful that none of these are perfect indicators, and most clinics utilize both of them to actually assess that how is the female doing in terms of ovarian reserves. क्योंकि अगर आप patient को help करेंगे with the assessment reproductive therapy, she should be having good reserves in the first place. You also need to see how is the tube doing, because you help everything and the tube is not fine. So you may need to do some X-rays such as hysterosalpingography or maybe sonography. You need to see the potency and the structural competency of the fallopian tube, because this is from where the zygote will ultimately pass and get to the uterus for implantation. Okay, right. So किसी वजह से अगर कोई previous PID हुआ है and this is blocked, then you will be thinking of some different strategy. Maybe you go for an ex vivo type of fertilization and then implantation, or it really depends upon what we are talking about. In different patients, the approach becomes different. Males also have to undergo assessment to identify if there is something wrong with the semen quality or quantity of sperms. So semen fluid analysis is the first one and perhaps the only routine in examination available. Many centers do that, and many centers recommend between a 2 and 4 day abstinence from ejaculation. So you kind of store the reserve and then you ejaculate it to fully examine what is the quantity and what is the quality, right? The new WHO criteria for semen analysis are here, and we will have a look there. You look for what is the volume of the semen. It should be, this is the normal range in terms of ml. What is the concentration? The normal should be, so normal and the range is here. The total sperm number, motility kaisi hai, this you see under the microscope. Morphology, normal forms, are they normal head and tail type, or there are bi-headed, or the tails are disturbed. What is the vitality? How much of them are live sperm? What is the pH? So these are all the semen fluid analysis. If everything is in the normal range, then everything is fine. But if, say for example, the volume is low, or the concentration is low, or the total sperm count is low, this is then something where you would start suspecting maybe the reason is coming from the male side. These are not average or median measurements, but they represent the lower reference limits, 5th centile. So this is important, because if it's even lower than 5th centile, this is really a problem. If the initial serum fluid analysis is abnormal, it should be repeated rather than immediately labeling somebody with problems. You repeat it, right? Some clinics will also assess total motile count. So sometimes they also do some genetic studies these days, a karyotype, to see if there are problems or microdeletions within the Y chromosome. And many commonly reported ones are, for example, these are AZFA, AZFB, but they are not routinely tested because, एक तो facilities भी available नहीं होती, and once identified, this is rather more for knowledge than action. How do you manage these patients? The management of the couple. So once you have identified that they have been trying for 1 year, there is no fertility, and you and the couple are convinced that despite appropriate attempts, they are not being able to conceive. This is where you label them as subfertile, and then you start investigation. You try to eradicate the cause, and then you start, after all these things, you then start helping them, managing the patient, right? It should be evidence-based and relies on the accurate diagnostic evaluation, history, पूरा workup होना चाहिए. ऐसे नहीं कि आपने बस फौरन जल्दी में start कर दिया help करना इनको. Maybe they are in the 3rd month, maybe they are in the 4th month, so be very careful. Ovulation induction is one thing that you can help with. So many females, such as with the ovulatory problems in PCOS, for example, they required induction of ovulation. Clomiphene is a drug that we have also previously discussed that helps ovulation by binding to estrogen receptors in the hypothalamus and pituitary. This blocks the normal feedback loop of estrogen and results in a surge of gonadotropin release. This is where the ovulation is then very much helped, and ovulation actually happens, right? The risk of, however, multiple pregnancies is there because clomiphene goes and sometimes multiple ova pops out, and this is something very common. And in clomiphene resistant women, alternative strategies include augmentation, metformin use of aromatase inhibitors. So sometimes you only use clomiphene, sometimes you help the patient with clomiphene plus other stuff as well. For unknown reasons, passing electrical energy through polycystic ovaries can result in induction of ovulation as well. So it's kind of giving the ovary a shock, and then it suddenly pops out the ovum release. In women with anovulation and hypothalamic origin का अगर anovulation है, then injectable gonadotropin is more effective. So it really depends upon what is the cause, and then you have to bring everything into context. Your history findings, your examination, investigation findings, and then you start, putting up everything together in order to treat the patient. Sometimes only clomiphene, for example, if it is PCOS, sometimes other stuff as well. And then you proceed with some other modalities which are also available. So for example, if you look at this table, which is summary of the medical and surgical management. So medically, you can help inducing ovulation. That's the first one that we talked about. There are others as well. And surgically wise, you can help with, such as you can do laparoscopy, but this will be in a particular scenario. Not every infertile or subfertile couple will start having operative laparoscopy, because you need to first ascertain why you are doing laparoscopy, कर क्यों रहे हैं. So for example, अगर आपने investigation में ये देखा कि जो fallopian tubes हैं, they are fibrosed and they are adhesions. So maybe now you decide that you have to do laparoscopy to to remove these adhesions, right? अगर cysts हैं उनको आपने करना है, tubal surgery करनी है अगर tube involved है, and so the decision basically depends upon what is your finding, what do you identify, and then you decide how do you treat it. Okay, even in vitro fertilization sometimes, so there are different techniques. Surgery to treat subfertility can be helpful in a variety of conditions. Most fertility surgery currently performed using the minimal access surgery, which is laparoscopy. Investigation of infertility and tubal potency testing by minimal is undertaken if the patient is symptomatic. So this is all what we have already discussed. Surgery is offered to those persons where you can alleviate the cause because of surgery. Okay. Often surgery may be used as an adjunct to the assisted reproductive therapy. For example, surgical disconnection from the uterus or removal of hydrosalpinges is associated with a significant improvement of IVF. So you're doing IVF, but then you are doing tubal blockade. कुछ cysts वगैरह हैं उनको आप बिल्कुल disconnect कर दें. So management of patients in the clinic always depends upon context. मैं हमेशा कहता हूँ medicine has to be personalized even at the level of a painkiller prescription. आपको देखना होगा कौन सा patient किस तरह respond करता है. Intrauterine insemination, IUI, is performed by introducing a small sample of prepared sperm into the uterine cavity. So this is not the installation of a zygote, but sperm, right? IUI may be helpful in cases with mild endometriosis and in couples who do not have intercourse, or a single woman or same-sex couples using donor sperm. So for example, if we are talking about a lesbian couple and they want to have a baby, obviously nature limits their transfer of sperm because both of them are females in this category. So external sperm is then inseminated into the recipient. Okay, she becomes the mother and labeled as the father perhaps. So it really depends upon the scenario. Okay, the success rate of this procedure ranges 10 to 20%. It's actually good क्योंकि natural अगर आप try कर रहे हैं तो भी 18-20% ही होता है ना chance. So this process may be processed by several days of mild stimulation. So female is stimulated to ovulate, and then इसको exogenous FSH देते हैं, and then the internal intrauterine insemination of sperm is done just to match the ovulation and sperm entry. Sperm entry here is artificial and controlled, and ovum release is stimulated by FSH or relevant drugs. Okay. इन विट्रो फर्टिलाइजेशन नाम बहुत ज़्यादा सुना होगा आप लोगों ने. IVF बहुत ही ज़्यादा फेमस है these days. It was originally designed for couples with tubal factor subfertility. इनके ट्यूब्स में इशू था. And these were the great physicians and scientists who performed the first case in 1978. There are now over 5 million babies who are the result of IVF. It's now used for almost all cases of subfertility, including the tubal disease, because इसमें transport का मसला है. So what you do is like you directly implant. So originally IVF was performed in the natural menstrual cycle, but now you can induce ovulation, assist things, and there are a combination of different things, right? So you can have multiple procedures because things are now advancing. So IVF has now actually very much modernized as the time passed by as compared to its first performance. Pituitary downregulation in the most commonly used IVF cycle, the pituitary gland is downregulated to prevent the endogenous LH surge and premature ovulation. So you have to suppress the natural system. A gonadotrophin-releasing hormone, again, agonist, is used to block FSH and L because you are doing everything artificially. ना आप in vitro fertilization कर रहे हैं. So you are trying to control the process of fertilization and implantation. So you need the central system to be shut off. Newer approaches involving the use of antagonists and shorten, so this is not something that you should worry about. Controlled ovarian stimulation. This is achieved using daily subcutaneous dose of gonadotrophin medication. You are controlling this, so you are number one shutting the central natural system, and then you are controlling the ovarian cycle. Close monitoring with a transvaginal ultrasound predicts the number of follicles and the timing of the egg collection. Ideally, around 15 follicles are recruited. So that's what you do. You recruit, you collect the follicles. Blood levels may be taken to measure the level of estradiol. So you have induced, you have stimulated ovary artificially, you have collected these ova. Okay. And then you get them fertilized in a dish, and then you put back the fertilized ova, the zygote now. Inhibition of premature ovulation, feedback from rising estradiol associated with follicular development should lead to LH surge from the pituitary, resulting the final oocyte maturation and ovulation. In IVF, this is blocked. You don't want the central physiology working, yeah, because you are in control. So you have to inhibit every ovulatory step within the body, which is physiological. Human chorionic gonadotropin trigger is used as a surrogate marker for endogenous LH surge. You have to inhibit it, okay? So this diagram then summarizes everything that we do usually in the IVF procedure. So what you are doing is you are collecting the egg. So egg collection is the first. Obviously, you are doing a lot of things before this. You are inhibiting the central HPO axis. You are doing exogenous ovarian stimulation. Anyways, at the end of the day, you collect a few good numbers of ova, and from there, you are doing fertilization, and then after fertilization you do the insemination, and then this is all in the dish. You see, embryo culture 2 to 5 days, and embryo transfer. This embryo is then collected and then transferred into the uterus again. So once the pregnancy is test, you do the, after that you do the routine pregnancy test, because यहाँ अब वो एक दफ़ा अगर इम्प्लांट हो जाएगा, अब वो चाहे नेचुरली इम्प्लांट हुआ या आपने इम्प्लांट किया है, if the implantation is successful, it will be having, you know, normal trophoblastic development, human chorionic gonadotropin levels will be there, and then you monitor the pregnancy as you do. So that's very successful procedure these days, okay? So basically ये उन लोगों के लिए डिजाइन हुआ था जिनमें देखें ओवरी थी, फेलोपियन ट्यूब का मसला था और यूट्रस ठीक थी, से फॉर एग्जांपल फेलोपियन ट्यूब ब्लॉक थी। तो अब इनमें क्या होगा, या नैरो थी या कंस्ट्रिक्टेड थी या स्ट्रक्चर था, इनमें अगर किसी वजह से जायगोट बन भी गया तो वो जायगोट पास ऑन होके यूट्रस में नहीं आ पा रहा था इम्प्लांटेशन के लिए। सो व्हाट साइंटिस्ट कम अप विद के वेल लेट्स डू IVF, यू नो, इस पूरे प्रोसेस को बाईपास करें, खुद से एक जायगोट बना के यहाँ यूट्रस में फिक्स कर दें। सो दिस इज व्हाट IVF डज एंड फैसिलिटेट्स, यू नो, इसीलिए इसका नाम है असिस्टेड रिप्रोडक्टिव थेरेपी ना, क्योंकि आप असिस्ट कर रहे हैं रिप्रोडक्टिव प्रोसेस को। एग कलेक्शन हमने ये बात कर ली कि यू डू इट आफ्टर अबाउट 37 आफ्टर ऑफ पोस्ट SCG ट्रिगर, बिकॉज दिस ट्रिगर इज एक्चुअली LH सर्ज, जैसे नॉर्मल बॉडी में होता है। दिस इज द ट्रिगर विच यू आर डूइंग एंड यूजिंग आर्टिफिशियली। अंडर एनेस्थीसिया अ नीडल इज इंसर्टेड इनटू द ओवरीज under obviously transvaginal control system. You know exactly you are entering into the ovary. It's a fantastic system. You have a big screen. You can actually see that this is the ovary. The needle is getting in there. You are collecting the ova. So you collect the egg. Basically, you do the fertilization with the sperm in the laboratory. Conventional IVF fertilization involves insemination of around 100,000 sperms in the petri dish with the egg. So ये dish के अंदर जो आपने egg निकाले थे female के वो पड़े हुए, and then you put like 1,000 sperm. So the chances of them getting fertilized are very very high, and fertilization is then checked the next morning, और फिर आप यहाँ से embryo pick up कर लेते हैं. So the embryos are incubated under strict condition. You try to culture the embryo, give them safe environment, give them like right humidity and temperature in special equipment, and once it reaches the blastocyst stage, you pick up that and you then get it back into the uterus. आप इसको दोबारा transfer कर देते हैं. So you transfer the embryo back into the uterus. So embryos are transferred into the uterus using a soft plastic catheter, and this is very safe procedure, right? आप सोच रहे होंगे क्या ही मुश्किल procedure है ये, but नहीं, this is done very very routinely these days. Embryo cryopreservation, many people also prefer to save these embryo, and this is also available now, and many people want to use them later, so that's absolutely fine. These days female cryopreserve their egg as well. Egg can be preserved and then taken back out, and then IVF done, and then, or some people can also even preserve embryo, right? Luteal phase support, the use of gonadotropin against agonist or antagonist to prevent the premature LH surge will lead to. अब देखें बात यहाँ क्या है, बात यहाँ पे ये है कि यूट्रस और ओवरी हमने पूरा मेंस्ट्रुअल साइकिल मैनिपुलेट किया हुआ है. यू नो देयर इज अ हाइपोथैलेमो पिट्यूटरी ओवेरियन सिस्टम ना, ये हमने पढ़ा हुआ है. FSH निकलता है, LH निकलता है, ओवरी पे जाता है, ईस्ट्रोजन निकलता है, ये सब आपने किया हुआ शट डाउन, क्योंकि आपने इस सबको शट डाउन करके आर्टिफिशियल ओव्यूलेशन, आर्टिफिशियल तो नहीं बट ये कि इंडक्शन उसकी आर्टिफिशियल करा के फिर ओवा कलेक्ट किए, जायगोट बनाया और जायगोट लाके यहाँ डाल दिया. तो अब जो नॉर्मल ओवेरियन साइकिल और यूट्राइन साइकिल था उसमें जो ईस्ट्रोजन निकल रहा था और ओव्यूलेशन के बाद प्रोजेस्टेरोन बन रहा था कॉर्पस ल्यूटियम से, यूट्रस प्रिपेयर हो रही थी, वो सब तो चला गया ना. सो नाउ यू हैव टू टेक केयर ऑफ दैट. यू हैव टू गिव इट अप्रोप्रिएट मैनेजमेंट. आपको प्रोजेस्टेरोन सप्लीमेंटेशन देनी पड़ेगी ताकि यूट्रस प्रिपेयर हो. दैट्स वेरी अंडरस्टैंडेबल. अगर आपने नॉर्मल मेंस्ट्रुअल साइकिल पढ़ा हुआ है तो ये आपको समझ में आ जाएगी बात. ART का सक्सेस रेट pretty much in young patients under the age of 35, it's around 40 to 45%. मैं हमेशा कहता हूँ it's a very double the success rate of a normal attempt. यानी अगर आप normal intercourse कर रहे हैं, the success of getting pregnancy, if all the odds are good, is around 18 to 20%. And this gives you a success of 40 to 45%, which is very good. Okay. However, after the age of 40, it will decrease down. Undergoing IVF does not preclude the patient from normal complications of pregnancy, of course, because आपने देखें यहाँ तक आर्टिफिशियल है मामला कि आपने जाइगोट इम्प्लांट कर दिया, इसके बाद तो इट विल प्रोग्रेस ऑन ऑलमोस्ट नेचुरली. तो जो बाकी कॉम्प्लिकेशंस हैं प्रेगनेंसी की वो हो सकती हैं. द मोस्ट सिग्निफिकेंट रिस्क ऑफ IVF ट्रीटमेंट इज ओवेरियन हाइपर स्टिमुलेशन, बिकॉज यू आर इंटरफियरिंग विद द नेचुरल साइकिल. सो यू नीड टू कीप आई ऑन दैट. ओके, यू नीड टू चेक दैट, इन्वेस्टिगेट दैट पीरियडिकली कि कहीं कुछ मामला हाथ से बाहर तो नहीं हो गए. GnRH, agonist protocols, agonist triggers, so you are playing with the central system, HPO, but humans have been very smart playing with these systems, right? IVF is of great success these days. Donor gametes, donor sperm can be used to treat patients with male. So for example, if a female is absolutely fine and this is the male and you identify subfertility का major cause male में है, that can be because of anything, impotence or low sperm count or low quality of sperm, something like that, right? And the female is not obviously comfortable having sexual intercourse with another male to get pregnated. So a technique there would be to get her ova out, इनके ova बाहर निकालें, डोनर स्पर्म लें, फर्टिलाइज कराएं, वापस डाल दें. सो इन दैट केस दे हैव अ बेबी. ऑब्वियसली दिस मैन इज नाउ नॉट द बायोलॉजिकल फादर, बट द बेबी इज प्रोड्यूस्ड फ्रॉम द डोनर स्पर्म. सो दिस इज हाउ द डोनर गैमेट्स वर्क. Okay. The same can also happen with female. I mean, change the scenario. The female does not have appropriate ova. What you do is, the couple or the male is not fine or comfortable having intercourse with another female, get her pregnant and then get this baby, and then so they are not happy with that. So a technique which is available would be a petri dish technique. Obviously, get the sperm out. These are the sperms here now from the biological father. Get the ova from somebody else. Now she's the biological mother. She's not, but then once the zygote is produced, get the zygote back in here. So she had the problem with ovulation, but now the uterus is fine, so you impregnate her with a zygote artificially produced. So ये आपको सारे concepts पता होने चाहिए, right? Surgical sperm retrieval, where sperm quality or quantity is low but sperm are still present, you can actually get to the level of the male genitals, get the sperm out and do IVF. This is also possible. Peri-implantation genetic diagnosis. Couples who carry genetic diseases but who are fertile may choose IVF and peri-implantation genetic diagnosis. So this is also something very important. They want कि IVF कराएं और यहाँ ये जो chromosomes हैं इनको check कर लें पहले. If everything is fine, then they proceed with the pregnancy and implantation of this zygote into the uterus. If there are problems, they may decide to abort the procedure right at this stage. Okay. Right. These embryos can then be genetically tested for relevant disease by the removal of the several cells. क्योंकि blastocyst बना है, बहुत सारे cells बन जाएंगे. You can check it very easily. Only embryos free of the disease are transferred into the uterus. And PGT has now been used very routinely worldwide, but this is illegal कि आप इसको सिर्फ gender selection के लिए काम करेंगे, ethical नहीं है. तो ये basically बात यहाँ पे ये हो रही है. This is an important concept to grab. Suppose you have a couple and this couple they have a history of genetic issues, right? इनके खानदान में हैं या इनके पहले बेबी में हैं. Now what they want is कि let's do IVF, right? Get the ova out, get the sperm out, do IVF. और यहाँ पे अब IVF में बहुत सारे एम्ब्रियो बन जाएंगे ना, क्योंकि what we talked about कि कुछ 30 के करीब एग आपने निकाले इस फीमेल से एंड देन 1 लाख के करीब स्पर्म्स डाल दिए. सो देयर चांसेस कि हो सकता है इनमें से 10 एम्ब्रियो बन जाएं, 20 एम्ब्रियो बन जाएं. सो व्हाट यू डू इज सपोज दिस इज एम्ब्रियो नंबर 1 एंड यू टेक आउट एम्ब्रियो नंबर 2, यू टेक आउट एम्ब्रियो नंबर 3 एंड ऑल द वे अप टू एम्ब्रियो नंबर जितने भी बने हैं, राइट? ये सब किस स्टेज पे होंगे? ये सब ब्लास्टोसिस स्टेज पर हैं. अभी आपने जब इनको पिक किया, इनमें बहुत सारे सेल्स हैं, आपने इसको चेक किया, पता चला इसमें जेनेटिक प्रॉब्लम है, सो आपने डिसाइड किया ये वाला एम्ब्रियो नहीं यूज करते यार, इसमें कोई जेनेटिक प्रॉब्लम नहीं है, इसको यूज कर लेते हैं. सो दिस सॉर्ट ऑफ थिंग. इसके लिए IVF और जेनेटिक टेस्टिंग कंबाइन की जाती है इन पर्सन्स हु आर एक्सपेक्टिंग और सस्पेक्टिंग जेनेटिक इश्यूज। लेकिन ये देखिए पॉसिबल नहीं है, ये इलीगल है कि आप इसको सिर्फ जेंडर सिलेक्शन के लिए यूज करें। सो फॉर एग्जांपल आपने IVF किया और अब मल्टीपल एम्ब्रियो बन गए। पहला एम्ब्रियो जो है वो पता चला नॉर्मल है लेकिन मेल बेबी है, दूसरा जो है फीमेल बेबी है। अब सपोज आपको मेल बेबी पसंद है, आप कहें यार ये वाला एम्ब्रियो इम्प्लांट कर दो, इस वाले को डिस्कार्ड कर दो। If that is the reason, this is illegal, unethical, this is not allowed. Okay? Fertility preservation. Patients may face treatments such as chemotherapy, radiotherapy, surgery. And for many years, men have been able to bank sperm. Couples can now. So this is something जहाँ पे जो freezing का concept है. Suppose there is a female diagnosed with a cancer. Now she requires chemotherapy. So before क्यों chemotherapy तो ओवी पे जाके hit करेगी, ओवा खत्म. So before undergoing chemotherapy, what she can do is get the ova out, cryo freeze them, and then these can be used later for IVF and pregnancy. So such a fantastic. Same applies to male as well. Sperm निकाल दें, sperm bank करें, freeze करें, बाद में use करें. Okay. So these are the learning points of this chapter. A careful history you have to take, appropriate examination and investigation. They are keys to the diagnostics. Then the couple should be given information on the chances of conceiving naturally. एक साल तक try करें, proper timing वगैरह सब set हो. Ovarian reserves decrease after the age of 40. Fertility treatment is a combination of expectant and surgical medicine, always a combination, and it is always personalized. You have to see your patient, right? What is required and what you should do. Treatments should be tailored to an individual couple's need. This is what I call personalized medicine. Fertility preservation and PGD are new effective methods. So this basically means के freeze everything. अब ये freeze आप ओवा भी कर सकते हैं, sperm भी कर सकते हैं, even embryo भी कर सकते हैं. Okay. Recent advances in verification have now also allowed young healthy single women to go through IVF and freeze their oocyte. ये मल्टीपल दफा बात कर चुके हैं. चलो एक आध केस देख लेते हैं, एक आध क्वेश्चन देख लेते हैं यार. A woman aged 34 years and her 32-year-old partner have had 8 years infertility and have attended a fertility clinic now. 8 years हो गए. The woman has been shown to have normal hormonal profile with normal ovarian reserve. When you do the transvaginal ultrasound, it is also normal. You did the sonography for fallopian tube, and the tubal patency is also fine. And the FFA serum sperm fluid analysis has shown that a sperm count of 6 million and a motility of 20%. Now, first thing that you should ascertain, female looks all normal, but do you think 6 million per ml and motility of 20% is good? Remember a table. We saw a table, and that is worth repeating now. Let's go quickly to the table of normal sperm analysis. देखें sperm total number कितना होना चाहिए? Million per ejaculate should be 39, which is around 33 to 46. ये देख के अब आपका पेशेंट जो है वो 6 मिलियन पर है. So obviously उसका स्पर्म काउंट काफी लो है, राइट? और मोटिलिटी भी रफली मोर देन 30% तो होनी चाहिए, और आपके पेशेंट की मोटिलिटी कितनी है? 20%. सो बैंग ऑन यू आइडेंटिफाई दैट देयर इज समथिंग रॉन्ग विद द स्पर्म क्वालिटी काउंट, है ना? व्हाट शुड बी द एडवाइस एंड मोस्ट सुटेबल ट्रीटमेंट फॉर दिस पर्सन? व्हाट यू शुड डू. So there are different ovulation induction. I don't think this is necessary. Female तो सारा कुछ ठीक है ना? और इसमें you should be going for multiple techniques. I would leave it to you. You may perform IVF or ICSI combination, intrauterine insemination, IUI directly, or you have to do IVF alone. IVF alone perhaps will not help, because you need to actually take care of the low sperm count, and you need to understand that motility is also very low. So if it is left to normal intercourse, it's not going to work. So the sperm count and motility is very, very low, and the IUI alone will have very low pregnancy rates. In IVF alone, the fertilization rate of egg will be very, very low, because sperm count is low to begin with, right? So resulting in a few embryos to transfer. Ovulation induction is not required because she is fine. There are no ovulation problems. So therefore PGD is not even required. अगर आप वरी कर रहे हैं कि PGD क्या है और ये terms मैं क्या use कर रहा हूँ, go watch my lecture और वहाँ से आपको terms pick होंगी. If the sperm count was below 1 million, further male genetic testing of sex chromosome would have been done. Absence of one VAS difference would indicate the need of cystic fibrosis testing. ये तब करते genetic testing जब ये सब indicators होते हैं. IVF and ICS will give good fertilization rate. So I mean, अगर आपने chapter सही से पढ़ा है तो you can pick it up, right? A 32-year-old woman and her partner are assessed for 2 years subfertility. Serum analysis has been checked and it's normal. And the woman has normal hormonal profile and normal markers for ovarian reserve. So everything looks fine. The transvaginal ultrasound is also normal. She has a 3-year history of premenstrual pain for 3 days before each period and constant right iliac fossa pain. This is where something wrong is there. What you need to do, you obviously now need to identify what is the cause, right? सबसे suitable test कौन सा है tubal potency के लिए, and pick up the single best answer. Although you can do hysteroscopy, a sonography, but remember there is, pain preceding menstrual cycle. So you need to be thinking something based on the history. The symptom raised the concern obviously for endometriosis. So in order to endometriosis investigation, सिर्फ ये अगर आप इसका स्कोप से देख लेंगे हिस्टेरोस्कोपी, you won't find anything, right? Endometriosis तो कहीं भी hidden हो सकती है. So आप सिर्फ यूट्रस को अंदर स्कोप से देख रहे हैं, it will not help you, right? Sonography of the fallopian tube should be used for a low risk women, but there is a persistent indicator towards endometriosis, right? So hysterosalpingography is suitable and will show tubal potency and would appropriate be for someone who declines surgery. लेकिन ये है कि अगर आप लेप्रोस्कोपी ही कर लें, that would then help you because it will enable simultaneous diagnosis of tubal potency, pelvic cause of the pain. अगर कहीं adhesions हैं या endometriosis है, you will be able to see that, and at the same time you will also be able to do the treatment. So the best option would be laparoscopy, and because this is both diagnostic as well as therapeutic, so multiple shots in one attempt. Okay. 36-year-old woman Jane, नाम भी बता दिया यहाँ, 39-year-old partner David have come to the fertility clinic after trying for 3 years. The referral letter notes that Jane has irregular periods. David has a hernia repair as a child. So there's a problem कि उसके reproductive tubes are disturbed, right? None of them have children. What important parts of history, यहाँ देखें ना, आप पूरा कट्टा चट्टा निकालेंगे हिस्ट्री में, कोई ऑपरेशन क्या हुआ था, उसके बाद क्या हुआ, वगैरह वगैरह वगैरह. इन्वेस्टिगेशंस क्या करेंगे, स्पर्म काउंट्स एंड सारी जो हमने डिस्कस की हैं ऊपर, एंड व्हाट ट्रीटमेंट वुड दे नीड डिपेंड अपॉन व्हाट डू यू आइडेंटिफाई एज द कॉज, राइट? सो दैट्स ऑल अबाउट दिस चैप्टर ऑफ सबफर्टिलिटी. Was pretty important. Now we will next begin chapter number 8, which is about the menopause. So once the menstrual cycle stops, and the post reproductive health, which is very, very important. So stay tuned and all the best till I see you next.